Alrighty, well, we are nearly at 1 o'clock, and it looks like we have a good group of folks already with us this afternoon. So I'm going to go ahead and get started. My name is Jillian Saul. I am Virginia Governor's Conference on Aging staff. Our webinar series is generously sponsored by Virginia Housing, and it is held every fourth Tuesday from 1 to 2 p.m. Next month's webinar is still in the works, but following that, we have a webinar in March on respite programs with George Worthington of DARS. You can find information about that webinar and the link to register on our website, which I will put in the chat momentarily. But I'm going to go ahead and introduce Sydney Palinkas, maybe a familiar face to many of you. Sydney works with the RAFT Dementia Education and Outreach Program, or is the Dementia Education and Outreach Coordinator for RAFT, excuse me. Sydney will be discussing dementia and elder abuse, understanding the increased risk today with us this afternoon. Just a quick couple of logistical notes for you before we get started. This webinar is being recorded. You may have been notified on your screens. It will be shared to the YouTube page. I will share that link in the chat also. You can use the raise hand feature once we enter the Q&A portion if you'd like to ask your question out loud, but otherwise feel free to submit all your questions through the Q&A box. That will just help us keep track of all inquiries, but we'll keep the chat box open if there's ever an opportunity for any open-ended discussion, or if you have any tech questions you'd like to direct message me. And there will also be a poll which will populate on your screen in just a moment, and that will be pretty straightforward, and we can explain more once we get to there. But thank you everyone for being with us. Really pleased to have Sydney with us to discuss how those who have dementia are more at risk to be faced with elder abuse, and how we can support our community and identify warning signs. So thank you everyone for being with us. I'm going to go ahead and hand screen sharing over to Sydney.
Thank you so much. And thank you everyone for joining. I'm going to go ahead and pull my PowerPoint up here. And before we really jump in, I think we'll start with the poll just to see where you all are coming from. So that should populate on your screen in just a moment.
Alrighty. So there should be a poll on your screen, and I will wait for us to get to about 70% participation before I close it.
All right, it looks like we have a good mix of folks from around the state and even some folks that are outside of the state. So welcome. I know I saw some familiar names in the chat box, but for those of you that don't know, my name's Sydney. I work with the RAFT program, and I'm also with the Virginia Coalition for the Prevention of Elder Abuse. So I'm going to talk a little bit about RAFT, a bit about VCPA, and then we will jump into the topic of dementia, put it together with elder abuse, and end with how to support survivors with dementia. So just quickly, the Virginia Coalition for the Prevention of Elder Abuse has been around since the 90s. We are an all-volunteer board, and one of the biggest things that we do is host an annual conference. This coming May, we'll be having our 30th annual conference, which we're really excited about. It's in Virginia Beach. Early bird registration is open right now. You can register at vcpa.org. We also, in addition to the conference, give out grants to local organizations that want to do more localized education or awareness efforts. In addition, we host webinars as well as have monthly newsletters, really just trying to support professionals in the aging field, legal field, anyone who might be coming across someone experiencing elder abuse. So that is one hat. The other hat is with the RAFT program, and some of you might be familiar with RAFT. We are focused up here in Northern Virginia, and we have two programs. The first one is our clinical support program, which has been providing services to older adults with serious mental illness and dementia with challenging behavior since 2008. And the goal of this program is to help discharge folks from psychiatric hospitals as they're moving to nursing homes or assisted living facilities, and then provide long-term mental health support to those folks in those communities. So they have that support, so they're able to be successful, and they're not kind of bouncing back and forth from the hospitalization. Just quickly, this is the referral process and the eligibility for the RAFT clinical support program. Folks need to be 65 and up, again, living in Northern Virginia. So that is Alexandria, Arlington, Fairfax, Loudoun, and Prince William. They need to be either in a psychiatric hospital or at serious risk for hospitalization. For this program, they need to have a diagnosis of either serious mental illness or dementia with challenging behaviors. And oftentimes we see people that have dual diagnoses. And the referrals for this program are coming through the CSPs. We also have a newer program, which has celebrated our third year, that is supporting older adults living with dementia that are still in the community, so in their own homes or the homes of a caregiver. This program is short term, so we're generally working with people for about 3 months with the goal of connecting them to long-term support services. It is completely free, so it is not based on their income or their insurance. And the goal is really to support caregivers, help reduce that stress, provide education about dementia, and connect them to resources. We also have a respite care program where the person with dementia can go and stay in an assisted living for up to 30 days. This is the eligibility for the dementia support program. Again, they need to be a resident of Northern Virginia, 55 and up, and either a diagnosis of dementia or symptoms of dementia. So we can work with folks if they don't have that diagnosis yet. They need to be living in the community, so in their own homes, homes of a family member or caregiver. And anyone can make a referral to this program. We really want to make that as easy as possible. So there is an online form which can be filled out by family, friends, or professionals. And our website is raftnorthernvirginia.org if you're interested in learning more about either of those programs. All right, so got the beginning part out of the way. Let's jump into the actual meat of this presentation and start off talking about dementia. So for my statistics people here, some stats about dementia. We know that 1 in 10 older adults is living with dementia in the US. About 2/3 of Americans with Alzheimer's disease are women. And there's some different theories about why this is the case. One, we know that our risk increases as we get older and women tend to live longer. Women also have higher rates often of cardiovascular disease, which increases their risk. We also see higher rates among older Black Americans as well as older Hispanic Americans due to different social determinants of health that cause them to have more of the risk factors related to dementia, such as diabetes, heart disease, etc. So you might be familiar with this graphic here. Dementia is an umbrella term. So we often use dementia and Alzheimer's interchangeably, but Alzheimer's is actually just one form of dementia, and we'll talk about the many different forms, or some of the many different forms, because there's actually over 80 different types of dementia. But you can kind of think of this umbrella with the term cancer, and then there would be many different types of cancer underneath. So dementia is just the range of symptoms that are associated with this type of cognitive impairment. It's sometimes called major neurocognitive disorder, so you might hear that as well. So for something to be considered a dementia, it's affecting our thinking, judgment, memory, movement, even vision. It's really interfering with daily life and daily functioning. And at least 2 parts of the brain are actively dying or declining. And unfortunately, at this point, dementia is progressive, it is not reversible, and will ultimately lead to death. So, as I said, there's many different forms of dementia. These are some of the most common forms. Alzheimer's disease, I'm sure most folks are pretty familiar with that. Vascular dementia can be caused by cardiovascular disease, diabetes, stroke, heart attack. Lewy body dementia, this is actually what Robin Williams had before he passed away. And often Lewy body does not begin with memory trouble. People will sometimes have hallucinations, stronger delusions, and then it will often eventually begin to have symptoms that look a bit like Parkinson's disease. So tremors, trouble with walking, and kind of a stooped gait. Not everyone with Parkinson's will have dementia, but some folks will. And again, this can look a little bit like Lewy bodies, and there is some overlap there as well. Frontal temporal dementia. This is actually what Bruce Willis has, and there's multiple forms of frontal temporal dementia. He has the form that affects his language. So he has what's called aphasia, which affects his ability to understand language as well as communicate. Some people have a form of frontal temporal dementia, that affects more of their behavior. And we see folks having very, very different behavior than they ever would have had previously. There's also a form that's less common that focuses on movement. We also see alcohol-related dementia. So very long-term chronic alcohol abuse can be the cause of dementia for some folks. And we're actually seeing an increase of that right now in our clients at RAFT. Dementia can also be caused from a traumatic brain injury. So this could be seen in maybe football players, other types of athletes, car crash survivors, as well as abuse survivors. One form of dementia that you might be a little bit less familiar with is called late. It is one that they are just sort of discovering and figuring out. It's very similar to Alzheimer's disease. The symptoms are a little bit milder, and there are some thought that folks who have previously been diagnosed with Alzheimer's, it was actually not, it was this form of late. And there's also a combination where we see people who have both Alzheimer's disease and late, and that would be called mixed dementia when someone has multiple forms. Often, though, what I see from family members is they don't always know the form of dementia. So we're just going to be talking about dementia as a whole today, but knowing that it really depends on the person and it depends on the specific type of how this will actually present. So when we think about what does dementia affect, what parts of our lives and our brains, it is eventually all of them. So we always think about memory, behavior, language with dementia. But the reason that dementia is ultimately fatal is that it will eventually hit the brainstem and the cerebellum. So that is our body's ability to regulate our breathing, to regulate our heartbeat. Swallowing can be a big cause of death for folks with dementia if their body is no longer sending those signals, right? If food is going down the throat, should I swallow it or should I inhale it? So all of those things can be big risk factors for folks. And we're going to go through some of the common changes that we see with dementia, starting with memory and cognition, the most common one that we chat about. So in the beginning stages, people are often losing those short-term memories, the things that they've recently learned, the recent events that have happened. They might be losing their train of thought more in conversations. They might be more easily distracted, just kind of that general forgetfulness. We do see some folks sometimes trying to fill in the gaps in their memory because that can be distressing for anyone to have this big hole in your memory. So the brain will sometimes create stories and create narratives to try to fill in those holes. As dementia progresses, people may no longer recognize their family members or they may expect family to be different or generally younger than they are because they're in a different time in their minds. They might also lose a sense of time. So not just, the date or the season, but also the length of time. So, talking with someone with dementia who maybe has gone out for a walk, and we might say, hey, how long have you been walking out here? They might tell you it's only been about 10 minutes, that they're close to home, when really it might have been hours that they've been walking, and that sense of time is just distorted in their brain. We do generally see long-term memories stay in the brain for a lot longer. People are often able to still remember things about their parents or have some of those long-term childhood memories ingrained. There's also changes that we see in language and communication. So people have a hard time processing information as we're talking to them. They might also have a hard time getting their words out. So this could be having trouble using the right words. So maybe they're substituting words that don't make sense, or they're talking around the thing. So as opposed to saying my water glass, I might say my water holder. So it still gets the message across, but not quite the word that we would have normally used. People might be repeating stories. I recently talked to a gentleman who was very coherent in terms of his speech, but within a 20-minute conversation, I heard the same story about 5 times. So we were kind of looping around. As dementia progresses, people have a hard time putting sentences together, and they might just start speaking less and less. One, because of that challenge, and also because they might be noticing that others are having a hard time understanding them, and then that can feel embarrassing and stigmatizing. If people know multiple languages, they're very likely to revert back to whatever that first language is. And we start to see people communicating more and more through their behavior. So they don't stop communicating just because they're losing those pieces of their language. They just start communicating more through their actions. There are certain types of language that are often retained longer in the brain. This can be rhythm, so things like music, prayer, songs, all of those stay in the brain for a bit longer. As well as what we call automatic speech. So things like, hi, how are you? Good. How are you? Okay, see you later. The things that we say all the time, we don't really think about it. That can stay in the brain for quite some time as well as, unfortunately, curse words. So words, bad words, words related to sex, and racial slurs are stored in the brain for a lot longer than other words. And I think that's really important to know because we might see people using language that they never would have used before. It can be really upsetting to family. And it's not necessarily that they want to use those words sometimes. It's that those are the only words that they have left to be able to communicate their needs. There's also changes in judgment and problem solving. So people have a hard time making decisions, not just good decisions, but decisions at all. And it's the beginning stages here that we'll often start to see people have trouble with scams and fraud. Now, scams and fraud are affecting all of us. I personally have had a huge increase on my phone lately. But I think we can all agree that there are some scams that are very sophisticated, and there are some that are a little less sophisticated. And it's at this stage that we might see people starting to lose money to some of those scams that they probably wouldn't have lost money to in the past if they had a little bit more of those critical thinking skills. People have a hard time processing information. Again, as I said, making a decision and then also initiating that next step. So we might see folks who have a hard time, doing tasks and getting things done. There's also a lack of impulse control we see in some people with dementia. as well as a hard time assessing for safety and risk. So, we all have alarm bells that go off in our brain when something's wrong. And for people with dementia, that alarm bell is getting a little wonky. Sometimes it's going off when it shouldn't because they're home and they're safe and they're with their loved one, but something in their brain is telling them that they're not. Or the flip side, where they're in a situation that's very unsafe, incredibly unsafe, but their brain is not telling them that this is an issue, that they should do anything differently. And one reason wandering can be a big challenge is people with dementia have a hard time retracing their steps. So, one piece of dementia that we don't talk as much about is changes in vision. And this is not changes to the eyes, but the way the brain interprets what the eyes are seeing. So, with age, there's a natural narrowing of our peripheral vision, just slightly though. But with dementia, this will be much more dramatic, and people may eventually lose all of their peripheral vision, which, if it comes down to sort of this level of eyesight, if you've lost all of that peripheral vision, you've then lost your depth perception. So people might have a harder time walking, right? Because they're missing most of that visual field. They might be misidentifying objects or people. They might be thinking that a pattern, like a pattern on my scarf, is something that they can pick up. So if you see folks kind of doing this on things, that can sometimes be the cause. There's also changes in motor skills. So these often don't happen right away, but one of the first changes would be issues with fine motor skills. So this is, putting in hearing aids, buttoning a shirt, putting on makeup, and we might see people having a harder time with those daily tasks. Eventually, they might have trouble with gross motor skills. So, getting in and out of the bed, walking, getting into the car. But those are retained generally for a bit longer, again, depending on the form of dementia. And strength is often retained for a much longer as well. So, lastly, there are changes in behavior and emotions, which I don't think is surprising given all the other things that people are experiencing. But they might be more irritable, a bit more overwhelmed by, sights and sounds, lights, and often they're withdrawing from their social circle. They might be less interested in activities that they used to previously love. And then some of the more serious symptoms, people might start having delusions where they strongly believe things that are not true. This could be delusions about theft, delusions that their home that they're in is not their home, or that maybe family members who've passed away are actually still alive. People can also experience hallucinations. So, seeing, hearing, or even smelling things that are not there. There's often challenges with sleep. So, our brains control our circadian rhythm, our body's response, to the light changing and the sun going down, and that can be affected with dementia. So people aren't getting those same cues from their brain of when it's time to sleep. But then this last bullet here, I think, is really, really important, that even as dementia progresses, people are still able to experience and recognize emotions. So if you are working with someone, or if you, care for or love someone with dementia, they might not always know who we are or what we're trying to share with them or what we're trying to do with them. But they very often are going to be able to pick up on our mood. So if we are cranky, if we feel like we're rushing them, if we feel like someone who is not safe, they're often going to notice that. Or the flip side, if we are someone who makes them feel safe, makes them feel good, regardless of knowing any of the other context. So just quickly, the importance of early detection with dementia. Oftentimes, people feel like because dementia does not have a cure at this point, that there's not always a point in detection. So, one, there are some medications related to Alzheimer's disease that can help slow down the progression a bit, as well as help with symptoms. And those are most effective in the early stages. But then thinking about our overall topic today of elder abuse and dementia, the earlier things are detected, the more support services can be put in place, and people will be able to help plan for their own future. So they might be able to be the ones to choose who they want that support system to be. Ideally, some of these things would happen even before a dementia diagnosis, but we know that's not always the case. So folks are able to choose, a safe power of attorney, a safe healthcare proxy, or even talking about supportive decision making and what that might look like in their family. All right, so I'm going to put it all together now with dementia and elder abuse. So this is a really common definition of elder abuse that's used. It's from the Elder Justice Roadmap, which came out in 2014. So it's a big, long definition, and we're going to break it up as we go. But elder abuse includes physical, sexual, or psychological abuse, as well as neglect, abandonment, and financial exploitation. So I think we often think about and hear about, like on the news, elder abuse happening in facilities like nursing homes or assisted livings. And it certainly can happen there, but it's also happening in people's private homes, as well as out in the community. So, an adult day center, a senior center. And it's most often happening in a relationship where there was some expectation of trust. So the older adult expected to be able to trust, their caregiver, their son-in-law, the person calling up and telling them they have an incredible deal on insurance, and then that trust is exploited. So elder abuse in the US affects about 5 million people every single year, which works out to about 1 in 10 older adults experiencing abuse in their homes. So just to go back to the beginning, you might remember that 1 in 10 older adults experience dementia. And I think we talk about dementia a lot, at least I do in my job. But most of us know someone who is living with dementia or have in the past. But we most likely also know someone who's experiencing elder abuse because it is just as prevalent. So, question here, and feel free to put your guesses in the chat. What percentage of elder abuse cases are never reported? And this is coming from studies that have been done of self-reports from older adults. So what percentage of cases are never reported to either the police or adult protective services? One guess of 65, 60, 50, 80, 85. So most of you are being pretty optimistic. It looks like there's a couple folks that got pretty close with 95%. And unfortunately, 96% of cases of elder abuse are never reported. So this means they are not getting connected to the resources they want. They are not knowing what their options are for the rest of their lives. And a lot of the survivors that I have worked with in previous roles, I used to work in an elder abuse shelter in Maryland, said that they really thought that they were going to end up passing away in this situation because they really didn't see any way to move past it. So I would assume everybody's sort of on board of why this is an important issue if you're already on this webinar. But just to talk about the impact of elder abuse, people are at a 300% higher risk of early death. They're more likely to experience depression, anxiety, suicidality, and also increased mental impairment. So they say that trauma almost has an aging effect on the brain, and people that maybe were early stages of dementia or didn't have a dementia diagnosis before experience an increase of that mental impairment after experiencing abuse. People are also more likely to need to go to the hospital and more likely to need nursing home level care. So the toll that abuse takes on the body is really high. Even emotional abuse, even verbal abuse, can take a big toll and stress on the body. So people that might have been pretty independent in the past are now more likely to be admitted to a nursing home. There's also very big, significant financial losses. This can be coming from family as well as stranger scams. And then, because of all of this, we're seeing people that are more reliant on social programs. So, they're having higher healthcare costs and then not having the same financial resources that they did at the beginning of this journey. So, who commits this abuse? We see abuse committed most often by family members. It's about 80% are from someone that the person knows. Some abuse, and I'll give a case example a bit later, really overlaps with domestic violence. So this might have been, a couple, they've been married for years. The relationship might have always had some form of abuse, and now they're also older. So it's kind of coming under that elder abuse umbrella. We also see abuse committed by family members, nieces, nephews, grandchildren, as well as caregivers, whether those are paid or unpaid, other professionals in their lives. And then less common, but neighbors, friends, or strangers. And I think certain types of abuse are more likely to be committed by certain people. For instance, they found that elder sexual abuse is more often committed by acquaintances and not someone that's very close. So, not necessarily a family member, but maybe a long-term neighbor. So I'm going to go through the different forms of abuse and what this might look like, specifically for someone with dementia. So physical abuse, I think the big ones we think about would be hitting, kicking, pushing someone. But this could also be over or under medicating someone. So perhaps we have a daughter who's caring for her dad. He is a wander risk, so he really can't be left alone, but she wants to go out for the weekend. Home health is pretty expensive, so she's going to give him so much medication that he's just sedated for maybe the entire day. Or maybe the flip side, we see someone who withholds pain medication from a loved one as a form of punishment. This could be using unneeded physical restraints on someone, controlling their access to assistive devices, like controlling their access to their glasses or their hearing aids. I once worked with someone whose husband would only allow her to use her walker when he thought that she deserved it. So otherwise, she would have to either walk really unsteadily and risk falling or just not be able to move around the house at all. We also see emotional or psychological abuse, and this can have just as big of effect on someone as physical abuse. So this could be, yelling at them, threatening them, maybe threats of, I'm going to put you in a nursing home, or I'm going to hurt the pets in the house. Not allowing someone to have access to friends or family. And then also religious abuse can be something that we often see with people. So this can look like using religion as a way to control them. So, you can insert any religion here, but we might hear, well, a good Jewish mother would give her son money when he asks. He would never kick her out onto the street. So using it to control them or potentially not allowing someone to practice their religion the way they want to. Sexual abuse, I know this one is harder to think about, especially with older adults, but it definitely does happen. And this is any type of non consensual sexual act. So, whether that's because the person did not give consent or can't give consent anymore because of dementia or another type of cognitive impairment. So, this could be inappropriately touching them, be using bathing or dressing times, forcing the person to look at pornography, or even taking photos without their permission. So, I was once at a senior center doing a presentation. It was about elder abuse. It was mostly about scams and fraud. And a woman came up to me after and she shared that her home health aide had been taking photos of her when she exited the shower. So when she was standing there, unclothed, waiting for help, this person was making her wait and taking photos instead. And it was really hard for her to share that. It had been happening for months and months, and she didn't want to share it. She was worried that the woman would lose her job, that she would have a hard time finding other work. But eventually, she did decide to share that information. And this was just a home health aide that she just had for a little while. They hadn't even known each other a full year. So you could imagine how much more difficult these things are to report when it's someone that they know very well or that they love, or maybe even that they're in a relationship with. Those are reports that maybe we don't get for a long time. There's also financial exploitation. So, this is the misuse of someone's money, possession, or resources. So, this could be, taking control of benefits, controlling bank accounts or credit cards. And this is often easier to do when we have someone with dementia who needs help with financial management and they are looking for that support. So we might see a family member who's actually not very safe coming in under the guise of supporting. So just an example here, of course, names changed for confidentiality, but this is Sherman, 85. He's living with Alzheimer's disease. He's a veteran, retired from the military after many, many years of service, very well respected and very, very active in his community. And in early 2023, before he had been diagnosed with Alzheimer's, he experienced a charity scam. And before anyone was alerted to it and anyone really realized what was happening, Sherman ended up losing about $45,000, which he felt very, very shameful about. He did not want to tell anyone. He felt like he must have been stupid, or maybe it didn't even happen. He really didn't want to accept it. And it was one of the first signs for his family that there was something wrong, that he might have been having changes in his brain. And then lastly, we have neglect. So this is depriving someone of their basic needs, maybe not providing proper medical care, not taking them to the doctor, not making sure they have the correct medications, not addressing toileting needs, or even locking them in an apartment or bedroom, saying, well, they're a wander risk. But of course, that is very unsafe. So sometimes people consider neglect to be not as bad or a little bit more benign. To just share an example from my community, again, names changed, but Jeffrey was caring for his father, Carl, who had dementia. Carl hadn't been seen by neighbors in quite some time. So even though they really didn't know what was going on, they made a report to Adult Protective Services because they were concerned. And what was found was that Carl was spending 24/7 every single day in a white plastic lawn chair in the living room of the home. He had trouble walking and moving, and Jeffrey was not bringing him to the bed. And because of that, Carl had a pressure ulcer on his bottom that was all the way down to the bone at that point. He had compression socks on that had to be cut off of him because they had been so tight and on there for so long. And when asked about all of this and interviewed, Jeffrey said, well, medical care is so expensive. I was doing the best that I could. But come to find out, Carl had very good health insurance, and he also had over $1 million in the bank, of which Jeffrey was going to be the sole beneficiary of. And unfortunately, very soon after this report to EPS was made and Carl was brought to the hospital, he ended up passing away. So, dementia and elder abuse. I'm not going to go through to all these studies, but the studies have ultimately been showing that about 50% of people with dementia will experience some form of abuse. And those numbers have been kind of verified through different studies throughout the years. One study done in 2010 found that 88% of the folks with dementia who had been mistreated by a caregiver were experiencing psychological abuse, just about 30% experiencing neglect, and 19% experiencing physical abuse. So we were seeing that people with dementia were more likely to experience multiple forms of abuse. Looking at elder sexual abuse, a study found that 60% of the survivor cases that they looked at were people living with dementia. So just another quick case example here, and this one demonstrates this overlap between elder abuse and domestic violence. So Ellen and Frank had been married for over 60 years, but during their marriage, Frank had always been verbally and physically abusive. We all know there's been big strides in the domestic violence field over the years, but when Ellen was young, there wasn't a lot of options and there wasn't a lot of resources. So now they're in their 80s. Ellen is living with advanced dementia, and she is depending on Frank completely. She needs his help with dressing and bathing and using the bathroom and eating. But Frank continues to be abusive, and now he uses her dependency as a way to have more control over her. So he might punish her by not taking her to the restroom, not providing her medications that she needs, and not taking her to her doctor's appointments. Eventually, Ellen ended up in the hospital after Frank very, very brutally sexually assaulted her. And this one does end in a good way. Ellen was able to live the rest of her life at an elder abuse shelter, and she got to receive a lot of holistic therapy in order to heal from this trauma. So, just quickly in the chat, what are some of the reasons dementia increases the risk for abuse? Some that we've covered already. Isolation. Yeah, absolutely. Viewed as an easy target. They can't remember or articulate what they've experienced. Caregivers are overwhelmed. Fear. Yeah, fear of retaliation. They're dependent on this person who's hurting them. They're less likely to be believed. That's a huge one. So just for the sake of time, I'll go into my piece here. Isolation was also the first one I had. People have less people to share this with, less people to notice. They have a harder time communicating. They also have a harder time with memory. The fear of retaliation, the fear of losing their caregiver. I have talked with many survivors of elder abuse who don't necessarily want this person to get in trouble. They just want the abuse to stop. So they're worried not necessarily about what's going to happen to them, but what's going to happen to this person who's hurting them. Sometimes the warning signs of abuse and dementia might overlap a little bit, like depression and anxiety and withdrawal. So that can make screening a little bit harder. And then there's also stereotypes about dementia and this idea that people almost lose their personhood with dementia. And that can also increase the risk of the way people view them. So I always like to talk briefly about this intersection between abuse and caregiver stress. So I spend all day, every day, talking with caregivers, and they are experiencing extremely high rates of stress. However, the majority of stressed caregivers do not abuse their loved ones. Most often, they are harming themselves in some way. And we'll talk more about that. It's what we call caregiver de-stress. And when we put too much focus on this idea that all elder abuse is caused by caregiver stress, it leads us to put in a lot of resources for the caregiver, but not enough resources for the person who's really experiencing this. And there's often a lot less accountability. So while caregiver stress might be part of the picture, and we might see stressed caregivers who struggle to provide proper care and maybe make mistakes, it is not the cause of abuse. So just some comparisons here between signs of potential caregiver stress and just de-stress or burnout compared to potential signs of abuse. Stress caregivers are most often neglecting their own health, missing their doctor's appointments versus neglecting their loved ones' needs. Many caregivers are experiencing financial burdens due to caregiving versus financially benefiting from that caregiver relationship. We might see caregivers who have mental health challenges like depression and anxiety due to the stress. They might be turning to drugs or alcohol more often to manage the stress versus a history of mental illness or substance abuse. Now, I am certainly not saying that caregivers who have this history are all abusers, but it is often part of the picture, and it's something to look at as one of the potential warning signs. We might see stress caregivers who do lose their patience sometimes, right? Who say things they don't mean, experiencing guilt, making mistakes because they don't have all the information that they need or the training. But then they are open to services, they are trying to get help. Versus someone who is being abusive and doing things as a way to gain more control and make that person more dependent on them, blaming the other person for their actions and really not interested in services. So this is not to say that the people on this side don't need support. We just might be coming at it from a different way. So ways to help prevent elder abuse: socialization for caregivers as well as people with dementia, finding ways for people living with dementia to continue having meaningful activities with and without their caregivers, making sure caregivers are educated about dementia and they have more tools to effectively manage the challenges, support groups, respite care, making sure healthcare providers are better trained to know how to screen and know the warning signs, and that we have better screening tools. So there are no screening tools at this point that are specifically designed for someone with dementia. So some tips as we end for how to support someone living with dementia who might have experienced abuse: making sure we're coming to them from the front, we're using a supportive, non-threatening stance, introducing ourselves, and really being aware of our body language and our tone of voice, as I said, because they might not be getting that content, but they are picking up on our other cues or gestures. And then really paying close attention to their body language, because they might not be communicating with words what's happening to them, but they might be using other behaviors. Try not to use too much logic in terms of correcting people or arguing. Instead, really focus on their emotions. We want to avoid multi-part questions or multi-step instructions and just really give people a lot of time to process. So quickly, because I know we're looking at getting close on time here, knowing the warning signs. So people who have been in the hospital very recently or very often, signs that they're not being taken care of. So poor hygiene, dehydration, malnutrition, financial decisions that are being made that are different than what they would have done or they could not have made, unexplained injuries, or injuries that are not being treated appropriately. In terms of the caregiver or family member, do they ignore the loved one? Are they overly defensive when you try to come in and ask questions or connect to resources? Do they allow you to talk to the older adult alone, or are they always right there? And how do they describe the person? Do they say, oh, don't listen to her? She's demented, she's senile, just ignore everything she's saying? And are they accepting of services and education? Looking at the home, consistently broken assistive devices or medical equipment can be a warning sign. If the home is unsafe or unhygienic, signs of hoarding, unpaid bills around the home, empty fridge, spoiled food, utilities turned off, especially if we know that a family member is supposed to be helping them manage those finances. And then some considerations when screening. We don't want to discount disclosures just because someone has dementia, but we also keep in mind that dementia can cause paranoia, delusions, and hallucinations. And sometimes what they're sharing might be more focused on a past trauma. So it's often about looking beyond the specific things that they're saying in terms of facts and more about their emotions. If you're going to be asking questions, always allow for extra time for this conversation. Avoid interviewing them in the evening and keep asking, letting the person know that you are safe and you are someone that they can share this with. These are some potential screening questions. So it's important to get to questions that look at a broad range of abuse, not just about physical safety, and that are broad. So one I really like is are there things that your caregiver does that you don't like? And that might get you a lot of answers, and it might also get you some reports of abuse. So when we're screening for abuse in individuals with dementia, we really need to be very good detectives. Angela Lansbury here. So hopefully everyone on this call, if you are a mandated reporter, you know what that means. You're required to report suspected abuse. These are the list of mandated reporters in Virginia. If you're not sure if you are one, definitely check in with your place of work. Reporting can happen either in the county where the person lives or at the statewide hotline. These are some additional resources, and you all will have a copy of this PowerPoint. So I'm going to go ahead and stop my share and see if there are any questions from the chat.
Thank you so much, Sydney. That was an incredible presentation. I certainly learned a lot. We have had a few questions come in. One just quick logistical question came in regarding the PowerPoint. Sydney did just mention, yes, we will be providing the PowerPoint to all attendees in the e-blast out to attendees in just a few days, along with the recording link. A question regarding dementia. Monique Marshall asked in the chat, does dementia affect hearing?
I have not heard that before. Untreated hearing loss can increase the risk of dementia. So, folks, as they're getting older, if they start to have trouble with their hearing and they're not getting that treated in any way, that can cause them to have an increase of mental impairment. But I have not heard that it necessarily affects their hearing. It affects people's ability to understand things when it's said to them, if that makes sense.
It does. Thank you, Sydney. And just a quick note from Joyce Williams in the chat. Excellent presentation. I have a question for you, Sydney. Do you have any tips or tools to approach an individual who may be resisting help once it's already been established that there is abuse taking place?
That's a good question. And it's a hard one because people are still adults. And unless they're deemed to not have capacity, they still have the ability to make their own decisions. And just because someone has dementia doesn't mean they don't have capacity, right? So that can be really hard when we want to come in and help someone, but they're not always open to the support. And that often happens when it's the person who's hurting them that they really love, and they might not want to leave that situation. So I think really approaching it with letting them take the lead, right? Like I've talked with folks who, a woman in particular, she was experiencing really bad financial abuse from her son. But what she really wanted was her son to get help with his substance abuse problem. But nobody was focusing on that. Everyone was focusing on her and trying to get her connected to resources. But that was really what she wanted. So I think listening to people, and we don't always have the ability to do all those things, but really trying to listen to them. And we might not bring them to what we consider full safety, but trying to keep them as safe as possible in the situation that they choose to be in.
Thank you. And obviously, so many of us in the aging, well, I shouldn't say us, but so many of those who work in the in aging related fields or in healthcare know that resources are tight for this industry in particular. But what would, the ideal response look like? Or how can, those who are tuning in from AAAs, for example, today,
Mhm.
how can they best implement response efforts?
Yeah, that's a great question. So I think in general, if you're not working with adult protective services already, making sure you're bringing them involved. I think there's a lot we can learn from the domestic violence field as well in terms of safety planning, and partnering with those folks in the community, because we know sometimes older adults are going there for support, but sometimes those organizations don't know enough about older adults and those specific resources. So I think building those partnerships is a great way to learn from each other. Um, and then I think really just kind of letting the person take the lead. There are some new promising things out there in terms of services. I think I had mentioned I used to work for an elder abuse shelter that was in Maryland. So that's a national movement that's happening. There's only about 22 in the whole country at this point, but it's a great resource if you're interested in learning more about it or implementing one in your community. It allows someone with dementia who couldn't go to a traditional shelter to move into a nursing home or assisted living facility while they figure out the next steps.
Thank you. And it looks like we had a question come in from Holly Copeland. Holly asks, is there any guidance for families of a person living with dementia who has started interacting romantically with another person who has dementia since neither can consent to those feelings or actions?
That is a good question. So we see this sometimes where both people don't have dementia, and that I think is often a little bit more concerning because there might be an issue of kind of taking advantage of that vulnerability. But this definitely comes up a lot, I think, in assisted livings or nursing homes. Um, and I think remembering that people might not have full capacity, but they often can make decisions of what they want to do and what feels good to them in the moment, right? And the decisions that they're making in terms of relationships wouldn't necessarily be the ones they would have made before, right? Both people in the situation could still be married, and that can be really hard for both partners. But most of the time, those actions are really coming from the dementia and not a reflection of that relationship.
Thank you. Certainly nuanced and yeah,
Mm-hmm.
complex issue. Yeah.
Yeah, absolutely.
Well, it looks like we don't have any, just lots of thank yous coming in. Any other questions in the chat is what I was trying to say. While I remind folks of some while I provide some final reminders, feel free to drop any questions you may have. The VGC Aging website page, which I linked in the chat when we got started, and I can do that again, is where you can find all information regarding upcoming webinars. It's where you can find the link to the recording of this webinar once it goes live. And that will also be on the VGC Aging YouTube page. I know Sydney is happy to be a resource if you think of any questions in the next few days after the webinar. And all of that information, including the slide deck, recording, Sydney's contact information will be put in the e-blast to attendees afterwards. I did see a question come in from Elizabeth Mallon. Elizabeth asks, how is that shelter funded? I'm not sure if you recall to which, I don't know if it was a specific shelter mentioned.
Yeah, so the shelter that I worked for was funded by private grants. There are some more funding opportunities coming through Department of Justice federally. Hopefully those won't change, but at this point, those are an option as well. And the Spring Alliance, I can put it in the chat, is the group that is sort of the national coalition for all these shelters. So they can be a good resource if that's something that you're thinking about for your community.
Thank you. And Sydney, I don't know if you have any final remarks, but I just want to thank our attendees for being with us today, and thank you, Sydney, for all of your insights. And I found this incredibly informative and helpful. So thank you.
Well, thank you so much. This is definitely a topic that I'm really passionate about, and it's always nice to see so many people hop on a call to also learn about it. So, thank you all. I hope everyone's having a nice snowy week. And please reach out if you have other questions.
Thank you, everyone.